Hello, I'm Chris Thompson from Brigham and Women's Hospital and Harvard Medical School, and my next lecture topic is going to be electrosurgical theory. My disclosures are listed here. There's no group of instruments in the surgical armamentarium that is used as frequently and understood as poorly as electrosurgery units. And that's a quote from J.L. Glover, who's an esteemed researcher in the field, and I believe this quote holds true today. I'd like to start by discussing some background on electricity and the history of the evolution of electrosurgical units, and then move on to waveforms and theory, and finally some suggested settings. So electricity, no matter where it is, in the sky, in the endoscopy room, in the OR, obeys a few basic principles. And these are that it always seeks the ground, it always follows the path of least resistance, and it must complete the circuit. The most basic definition of electricity is the flow of electrons from one atom to another. And essentially, we can utilize this charge, harness it to do work. Some conductors are, of course, better at transmitting this flow than others, and the more free electrons a material has, the better it conducts. Some basic principles we should all be familiar with, at least in distant past. Voltage is the difference in charge between 2 points. This is potential energy, essentially. Current is the rate at which charge is flowing. Resistance, otherwise termed impedance or tissue impedance, is a material's tendency to resist the flow of that charge. And the circuit is the pathway for uninterrupted flow of electrons. Some other units, energy is typically measured in joules or watt seconds. Power is in watts, and frequency is hertz. This is Ohm's law, which is somewhat relevant here, where we have volts is equal to current times resistance. Analogy that may help us to remember these concepts or understand them is the water tank analogy. And here we have water in a tank, and the water represents the charge. Pressure, how much water is in this tank and how much pressure it's exerting, is the voltage, equivalent to the voltage. The flow of this water is the current, and this is measured in amps in the electrical system. And the pipe width would represent resistance, and then the work that can be done is the watts, the power, how it spins this water wheel. Getting a little bit into waveforms, right? This is important here. These longer waves, 60 hertz, are equivalent to household appliances. And these are the dangerous ones, right? Because they're kind of in sync with our own nervous system. And this is how we can become electrocuted. As you shorten those waves up, and they become more intense here, this is where we get into the 300 to 500 kilohertz range, and this is where we see electrosurgical units. Transformers can be used to adjust the frequency of these waves, and that is what is in the electrosurgical unit. And here are the first two electrosurgery units. The first invented by Christian Irby in 1923, and the second invented by William Bovey and Harvey Cushing at my hospital, the Brigham and Women's Hospital, in 1926. And what these essentially do is they transform energy from low frequency to high frequency, and then onto heat in the body. So what is electrosurgery? It's the use of electricity to cause thermal destruction of tissue through cellular dehydration, coagulation, or vaporization. And how does it work? Well, as high-frequency alternating current passes through tissue, electrons collide with various tissue components, energy is dissipated, and heat is generated. And then that rise in temperature can have two effects on tissue. It can cause coagulation, or it can cause cleavage and cutting. Now, this is a typical clinical circuit. You can see electricity is going to flow from the electrosurgical unit to the instrument, and that will then interact with the tissue and go through the tissue, back to the return electrode, and then this is a neutral electrode, and then it will go back to the electrosurgical unit. And these terms are the same as we've already discussed. We have the circuit, we have the current flowing, electrons flowing through the system. Voltage, this is the electrical force pushing the current around the circuit through varying degrees of tissue resistance. And then impedance, which is the resistance to the flow of charge, which is typically from the tissue being treated. And these tissues have varying consistencies that we'll talk about that are important. Now, in a bipolar system, this does not have to go through the body, so it can create a circuit coming right back up through that instrument itself. Now, there's not a lot of instruments we use like this. Some instruments used for coaptive coagulation, like a gold probe, would be an example of this. So what about that resistance is another important element to this, or tissue impedance. Well, there's a spectrum from tissue that's considered to be a good conductor, such as a submucosal space, filled with some fluid. That's a good conducting tissue. Mucosa is fairly good. Muscle, okay. Then when we get into skin, it's a little less good of a conductor. Fat, now we're getting more into kind of insulators, if you will, and bone, of course, they do not conduct well at all. There's other factors to consider here as well with impedance, and that is age, disease process, body build, how much muscle they have, and hydration status. Back to our basic principles. Electricity always seeks ground. The patient should be clear of electrically conductive objects such as the IV stand, the bed rails, etc. There should be padding, to avoid accidental contact, remove any metal jewelry and piercings. When you don't, this can happen. Now, newer electrosurgery units are really designed to prevent this from happening, but it's still best to be very cautious. So these are alternate site burns, where foot's resting against a bed rail or IV pole. And back, you can have this with electrical leads, etc. So very important to just keep this in mind, even though it is less common now with modern technology. What about the neutral return electrode here, the dispersive pad? There's some safety rules to follow. The area should always be clean and dry, which means no hair. Hair is an insulator. It can get very hot. It can even catch on fire. So you want to make sure there's no hair, there's no fluid under this pad. You want to put this on an area where there's good musculature and vascularity. A flank is a good spot for that. Avoid any bony prominences or scars. We know bone doesn't conduct well. It's going to be an issue. You want the smallest circuit possible. You want this close to the electrical surgical site. You want to avoid tenting when you place this down, and you don't want to cut the pads. All this is very important to avoid any return electrode tissue damage or burns. Moving on to tissue effects. Now here we have cut and coag. In the upper left, we have cut. So here you see a cutting waveform is a sinusoidal waveform. It's relatively low in voltage, but it's over 200 peak volts. And this quickly raises the temperature in the cell above the boiling point, so it's above 100 degrees, and the cell explodes, separating it from adjacent cells and creating a cleavage plane, or cutting, as you see over here on the right. Alternatively, a coagulation waveform is characterized by high voltage spikes. It's intermittent, okay? It's not a continuous sinusoidal waveform. And this typically has much higher voltages, 1,000 to 4,000 range or more. This allows the cell temperature to more slowly increase, and this causes tissue to be devitalized when the temperature reaches above 60, and beyond 80, the proteins are denatured and coagulated, and the tissue shrinks and desiccates. And this can be used for hemostasis, vessel sealing, tissue coagulation. And you can see there's an exception to this in the upper right here, this left-hand tissue sample. This is a sinusoidal wave of less than 200 peak volts, and that doesn't reach the level needed for cutting, so you can actually coagulate here the sinusoidal wave of lower voltage. So that's that basic principle. Getting into waveforms, because there's some more specifics we can discuss here. Here again we have endoscopic cutting, which is that continuous sinusoidal waveform. Waveform is certainly one principle that's very important when we're discussing cutting versus coagulation. Duty cycle is also important, right? How often is this, waveform active? Is how often is it on? And for pure cut, it's on 100% of the time. For pure coagulation, it's on around 6% of the time, right? There's greater pauses. So these are important to keep in mind as well. And then we have various types of blended currents, if you will. So here we have something equivalent to dry cut. We're up higher in voltages on the y-axis. We have voltages, right? So now we're getting into the thousands. Here we would have something such as swift coag. Okay, this is the transition point. I start using the blue pedal instead of the yellow pedal. We have forced coag, much higher voltages, and spray coag, of course, with incredibly high voltages, relatively speaking. And then here we have our soft coag, which is, again, is sinusoidal, but it's lower in voltage, so it can be used for coagulation. Now I'll show some videos demonstrating how these waveforms are applied. First, we have marking, and for this, we typically use soft coag, less likely to cut. Here we're sealing a vessel with a coag grasper. Again, soft coag, that nice low voltage sinusoidal wave. Now we're making an incision, and here we are more into a blended cut type pattern, as you can see here. So maybe dry cut would be used for this, an example. And here we're using a blue pedal, and we're dissecting through the submucosal space. So maybe we're using some swift coag. It's not a huge spark. And now sealing a vessel as we go through here. A little bigger spark, maybe we're in some forced coag there. Moving on to Endocut. This is a specialized waveform that involves a fractionated cutting mode characterized by controlled spark recognition, alternating cutting and coagulation cycles. So here we have that initial spark, which starts the incision, and then we have cutting waveform interspersed with coagulation waveforms. And this is what the unit looks like, the display. And we have two different modes. You have an I mode, which was originally designed for performing a sphincterotomy or for using electrosurgical knives. And then we have a Q mode, which was originally developed for snares, but you can kind of use these a little interchangeably. And then you can select your settings. And the first is effect, and this is helping to adjust the level of hemostasis. The second one is cut duration. That's how long you're in that sinusoidal cutting pattern, okay, how long the cutting is on for. And then you have the cut interval, and this is the time between those cycles when you're more in a coagulation mode. Then you have your forced coag settings over here for this example. Common settings. These are relevant to the Irby Bio 300D units and different knives. So IT knife, hook knife, dual knife. And you can see these are typical settings. You're going to vary these based on your patient, based on where you are in your procedure, if you're in the submucosal space, if you're making your incision, if you're trying to do hemostasis, etc. And you can see some examples here for incision, Endocut I, effective 2, cutting duration 3, cutting interval 1. And you're gonna adjust these on a patient-to-patient basis. And in subsequent lectures or during live cases, you can inquire about why people are choosing the settings that they're using and try to develop an understanding of this. Dry cut 50 watts, effective 4 is a common setting with an IT knife. When you're getting into your dissection, okay. Endocut I, 2, 3, 1, again, pretty common. Dry cut of 50 and somewhere between 2 and 4 with effect. And then with hemostasis, you can consider using swift coag with this, 50 watts and effective 4. So you can kind of see with hook knives and dual knives how this changes. A dry cut with a dual knife for the incision, 30 watts, effect 2 to 3. Hemostasis, 30 or 40 watts, effective 4. Coag graspers using soft coag is not listed here. Usually do 80 watts, effective 5. So, and then with a hybrid knife, these settings are different as well. Finally, what other variables are impacting tissue effect? Well, we've alluded to some of this already. Type of generator is important, waveforms, of course. The type of electrode you're using. So what type of electrosurgical knife, how small is it? The smaller it is, the greater the current density. Physician technique, using the tip of the knife is typically better. Again, focusing that tissue current density. Pad placement, patient variables, age, body type, hydration, length of activation, again, getting into those waveforms a little, and anatomic location. In conclusion, understanding basic electrical principles and tissue characteristics are important for the proper and safe use of electrical surgical units. Understanding waveforms and device settings can help optimize desired tissue effects. And patient factors, type of accessory, and physician technique are also important variables that can impact tissue effect. Thank you for your attention.